have a good tube placement. We know we're in, we've got our multiple verifications on it, and we're not getting CO2 above a certain level. At what point do we just say, you know what, this is really something to consider calling?
Okay, there's a few other things Lori's going to talk about
Okay.
that can also affect CO2, and we'll
Okay.
use those. The second half of this, we're actually going to do clinical cases and some problem solving,
Okay.
and we're going to run through some of those
Perfect.
scenarios.
Good question. So that's why we're going through this now, and then the case presentations are going to kind of help put it all together. And sometimes just having information is great, but then applying it is kind of where I'm always at. I always want to know how's it going to work for me in my practice. So reasons for end-tidal is being 0, as we talked about, is that the tube's in the esophagus. Also, it could be for patients who have had prolonged downtime or rare cases like a massive PE where you're just not getting any flow to the lungs, and so you could have a 0 end-tidal. But that's just a very rare case. Also, in patients in arrest, CPR is necessary to generate a waveform. Just remember that too, because sometimes you start bagging, it's like, well, I don't have anything. Well, you need to do CPR. You need to have perfusion going there. In patients with a prolonged downtime, the end-tidal CO2 reading may be very, very low. So you may get even like 6 or less. But as long as you've got a waveform, a square waveform, and you're getting a number, especially for a patient who's been down for a long time, you are verifying that you do have placement in the trachea. So keep that in mind too. Don't panic and think, well, my end-tidal's only 5. Well, you're right, because this patient's has been down for who knows how long. So just keep that in mind. A small but distinct waveform is all you need, and then document that accordingly. And keep your end-tidal on. Don't just put it on and then take it off. Continue using it throughout your transport. So esophageal versus endotracheal, the first strip there is not what you want to see. Flat lines are never good in any case, but for intubation, you definitely don't want to see a flat line. That is what you want to see. That's a very low end-tidal CO2. What? You have an end-tidal. So it's probably what, like a 10-ish or something like that. So that's what you want to see when you put your end-tidal on. Also, make strips of your end-tidal. When you get your patient on end-tidal CO2, hit strips or do a summary afterwards, so you have that documented in your chart or your PCR that you have actually done your end-tidal CO2 and you have a waveform to put it.
Now I have one question, but it's more monitor related. So if we highlight end-tidal CO2, so we're reading it on the screen, when we print a strip from that, does it show up? Do we know?
Yes, it does.
Okay.
But not in a code summary. You have to
Say again?
snapshot.
You'll have
to
to
snapshot.
snapshot.
You have to hit snapshot in the summary, but if you just hit record and you have it on screen, it'll give you the waveform.
It will, okay.
Yeah. It doesn't come on summary at all. That's
Only
what
if you hit
snapshot.
snapshot.
If you hit snapshot, yes.
Side stream too.
Yes, exactly. Side stream would be the same. So just do a snapshot or push the button and or get someone else to push it so you've just got a strip for yourself and then put it on your PCR. Okay, that's an esophageal intubation. So like Dr. Georgie was talking about, you'll initially get this little whiff, little puff of CO2, and then it's like, oh, that's not good. So that's more than likely what you're going to see. There's little or no CO2, and remember, trending is important. Just because you got that initial little puff there, that's not a good waveform at all. You usually never see that kind of waveform, and then it just peters out. So that is an esophageal intubation.
Does our monitor show a trend if you haven't, like, say you just attach your end-tidal on a code, you know your tube's in, you're not paying a whole lot of attention to the numbers because you're giving meds, doing everything else. You know what it was when you first put it on, and then you get to the hospital and you see it. If you haven't pushed snapshot or anything like that, is there a trend that's going to show you what those numbers were, or you have to pay attention only then?
I have to look at it.
It records every time you push something, like if you push
Right, but I'm
the
saying,
picture, but
yeah, if you
don't,
don't
it won't
push
record it.
anything, is it going to give you a trend?
I think it'll.
So if you snapshotted a bunch, is it going to give you a trend?
I've never seen it produce
It
a
would.
trend
I'd have to
waveform.
look. I don't know
That
if it
is
does
a
or
really
not.
good question,
But
actually.
I know that the only stuff that gets stored within the monitor is by pushing the snapshot, not by pushing the
Or
record button.
like she said, blood pressure. records.
Yeah, it'll give you an empirical value.
But if you're not taking a blood
But if you're not
pressure,
doing it,
sure.
but pressing snapshot, it will store it.
Right, but I'm just wondering, like, because you know how you can go back in and get like all your blood pressures only, would it give you a trend?
Oh,
of
yeah.
the-
Yes, it will.
It'll give you the numbers of it, but it
You'll
won't
get
give
the
you the
numbers, you won't get a
graphical.
waveform, but
Right,
you still have
right,
numbers.
but you'll have numbers,
Yeah.
but only if you push snapshot on it.
Yeah.
Okay.
Is there a code marker for ETCO2? No, like,
No, it's just meds, I believe.
Well,
snapshot
Yeah,
is
because-
easiest because
Yeah.
Yeah.
Just snapshot.
Yeah.
Right.
It's better to do a snapshot than to try and mess around printing, because
Yeah.
if you, especially if you're coding, don't be messing around.
Yeah,
Just do a
forget it, just
snapshot.
snapshot it,
Yeah.
have somebody,
Snapshot's really nice because it's just kind of saying,
Yeah.
record
boom,
that.
and then you got
Or
it.
like
And
every
then
5 minutes, so that
even
way
if
you
you're-
have a trend.
If your paper, gets some snagginess not coming out, you want to.
That never happens, does
Right?
it?
But, I mean, even if that's the case, every time you hit that snapshot, it's gonna be recorded in reminder, so you can forward later.
And like I talked to Laurie when I was okay, standard practice, I had transport patients, was right as I transfer them in the ER, do not take the monitor off until you hit that snapshot, because if the documentation of it comes back, say, was that tube in? Yes, there's the ER time when I transferred that patient, and there's my snapshot with my square wave form, and there's my numbers. And that's it, that's my hours saved in the court of law. I tube that patient on, so.
It's true though. It's very true.
I use SiteStream on most of my respiratory calls, and I always get trends. But that's if you apply it, you make sure you press the CO2 button, and then after that, anytime you take new vital signs, press the blood pressure, when you print out the trends, the CO2 levels do come out.
You have to make sure the log is not
The log is not full, yes, that's another little
And make sure
issue.
you press the CO2 button, because a lot of people plug it in.
But they don't have the waveform.
Don't forget to push the, okay.
Oh, and actually, speaking about that, before you actually put the CO2, you hit the button first,
Mhm.
and you allow it to calibrate. Don't automatically put your plastic tube in, because it will actually give erroneous numbers or it mightn't work. So if you notice on the CO2 line, it'll actually calibrate, and then once it gets the zeros right, then you plug it in.
This, that only takes like
Yeah, it's
seconds. It doesn't
Yeah,
take,
makes it more accurate.
yeah. So just have someone turn it on and get yourself ready to go, so, yeah. So this is the kind of waveform that you're gonna see with a patient who's hyperventilating, or maybe you're hyperventilating and you're bagging your patient too fast. The capnography starts normal, but as the rate becomes faster and faster, the waveform becomes closer together. And so the farther spread out your waveform, the slower the breath, the closer together, the higher, or the actual number. The most common cause of hyperventilation is overzealous bagging of nurses or medics. When decreasing end-tidal CO2 levels are noted, simply slow the rate down in which the patient is being ventilated until the end-tidal returns to normal. You may not always get a normal number, but at least you know that you're ventilating way too fast, you're hyperventilating the patient. In the spontaneous breathing patient, increasing respiratory rate and decreasing end-tidal CO2 levels can be a sign of hyperventilation syndrome or pulmonary embolism. You know, the thing is with end-tidal CO2, you're not going to be able to diagnose your patient, but you can start going through in your mind what might be some possible causes of this issue. Are they just hyperventilating? If they're intubated, you're probably bagging them way too fast. So you just need to slow it down a little bit. And we've all done that. You get going and you're bagging the patient, and then you realize, oh, I don't have to bag it 30 minutes. Hyperventilation with a high end-tidal CO2. If a patient has a high respiratory rate and a high end-tidal, the problem is potentially the metabolic problem. And again, in the field, you're not going to be able to figure this all out, but you might see it on patients that are like in DKA and sepsis. These patients are acidotic, salicylate poisoning, you've got your aspirin overdoses, renal failure, methanol ingestions, and tricyclics, which we don't see that often anymore. But still, just reasons that you might see patients hyperventilating and you might have an end-tidal CO2. This would probably relate more if you had your patient on SideStream. And most likely, you're probably not going to have a DKA patient intubated in the field unless they have some other issue going on. But these are your patients that you might have them on SideStream. And SideStream, I think, is just kind of interesting just to see where they're trending, what's going on with them if you really feel that you need to monitor their end-tidal CO2. So that's what you will see.
Or
Hi, go ahead.
One thing that I think that's good too, just with the side stream and the trending, and it's a good measure of how sick they are. You know, yesterday I got to go on a call where we used side stream, and then you could tell the patient was retracting, they were hyperventilating, they had definitely some metabolic issues, and I like to do this thing where I'm like, use the side stream, and then let's guess the number, you know? And I found that really it's oftentimes more normal than you think it's gonna be, which I think you guys are gonna get into normal readings when they shouldn't be normal. But this guy was higher, and he was hyperventilating as well. And so it was a good indication for the medic, who definitely put it in high gear in terms of like, I thought this guy was sick, but he's way sicker than he may look at the present moment.
Well, they're hyperventilating because they're trying to blow off all that CO2, so they're hyperventilating, but they have a high end tidal. And so many times it's because they're in DKA, you know, those DKA patients that are breathing really rapidly because they're acidotic, they're trying to blow off all the CO2. The septic patient, you may see them come in. Dr. Lum just did a whole case presentation on that patient that was septic, that he had necrotizing fasciitis, but that was his biggest presentation. He came in, he had a super high respiratory rate. We thought he had an aspirin overdose because he was breathing at like 45, 50 a minute. And he'd been taking a lot of aspirin for the last few days. Turns out that was not his problem. He had way bigger problems than aspirin, but, and that patient ended up dying within 12 hours because of necrotizing fasciitis. But he was septic. That was the bottom line. And again, you're not gonna be able to diagnose by this, but it kind of sends you through a process in your head of what's going on, what potentially could be going on with this patient. So using SideStream is really a good tool.
So if someone...
What's happening in all these cases in sepsis is that the body's metabolism is really revved up. In fact, it's out of control. Like salicylates, that's uncouples oxidative phosphorylation, meaning how we form ATP through the after the Krebs cycle is just spun out of control, and so we're not even producing efficient energy that we can use. But anyway, we're producing tons of CO2, and sepsis, that's what happens too. You know, you're sick, you actually aren't, your metabolism isn't efficient whatsoever, and yet you produce loads of CO2s. And that's how come you hyperventilate. You're trying to blow that off because remember, CO2 in your bloodstream turns into an acid and makes the pH really acidic. So that's how come you'll be producing a lot. But you look at those people, come on, you know, you've seen DKAs, right, who are hyperventilating. Do they look like a patient who's got obstructive lung disease? No. They're moving air really fast and efficiently. You've got no trouble recognizing that. And so when you see that high end-tidal CO2, you're going to know that it's not a problem with an obstructive component to their airway. So, yeah. Jenny?
Someone who's just hyperventilating for anxiety reasons, you're obviously a high respiratory rate, but what would you expect to see their CO2 levels be because they're not septic or anything? Are they going to be?
They're going to have the low
because they've blown off so much.
Which is, and that's why I really am going to, we're going to have fun in the second half, the case solving, because there's that tendency to think, oh good, you know, the CO2, this is abnormal, we got a PCO2 of 25. Oh good, it's coming up. Is that a good thing or not? You know, is it that, oh good, they're not hyperventilating so much anymore, now their CO2 is coming up. That's where you got to look at everything together, and so we're going to have some fun with some simulations.
So hypoventilation, it can be caused obviously by a myriad of things. Every hyper and hypoventilation can be caused by a lot of different reasons. It can be respiratory or metabolic. Metabolic is a lot harder to figure out, but like with those DKA patients, like Dr. Giorgio said, they look like they're breathing just fine, but it's a metabolic problem. That's why their end-tidal CO2 is off the chart. But hypoventilation can be caused by, you know, the overdose, the altered mental status, intoxication, they're over-sedated, head trauma, CHF. There's a myriad of reasons. And it can be also involved because maybe they've got cardiac issues, so their cardiac output has been altered, fever, sepsis, pain, all those things. CO2 retention in a head-injured patient leads to increased cerebral blood flow and blood volume, and this results in increased ICP, which is what we don't want to do. resulting in hypoxemia and increased mortality rates. So just something to think about too. So that is the kind of waveform that you're gonna see on a patient who's hypoventilating. Maybe they're on side stream, maybe they're an overdose, you put them on Entitle just to see where they're going. You gave them Narcan, they were doing okay, and you know how it goes, they kind of start going down again, and you'll start seeing their Entitle CO2 rise again because they're hypoventilating. They're not ventilating efficiently. So that's gonna be your trend, and that's how it's gonna look. So keep that in mind. This is an example of a patient who potentially, they were intubated, but maybe it's leaking around the cuff. And so you might have a leaky or deflated endotracheal or a trach cuff, or the airway is too small for the patient. So you're still ventilating the patient, but it's not the best. Obviously, if you can still maintain and get to the hospital where they can change it out, that's great. If not, then you need to do. If you start losing your Entitle altogether, you need to obviously take your tube out and just go ahead and bag the patient. You're better off that way. But that's the kind of waveform you're going to see. They kind of call it a shark fin presentation, where it's kind of looks like a shark fin. And so you'll see that in patients where maybe the seal is not adequate. When you're in the middle of a code, you're probably not going to be just looking at this waveform continuously, but it kind of gives you an idea of what's going on, especially if you've pushed your snapshot and later on you can look at it and go, oh, okay, that's what was going on. This is a patient, another waveform that you may see, where they have an obstruction. So it can be, obstruction could be from a lot of different reasons. It could be just your ET tube is kinked. You know, so you're bagging and maybe there's too much tension on the tube, and so your tube is kinked, and you might see this, and that is a sign that potentially you've got an obstruction. You may have a foreign body. The patient may just need to be suctioned. That might be a whole nother issue, and you may just need to suction your patient, or bronchospasm. So,
George, if we can go back.
yes.
I like to call, this is more like an orca fin, okay? Because, again, this is so confusing to me. To me, it's counterintuitive when you look at these waves, what we're really trying to look at, because it's the opposite sort of pulse oximetry in terms of which way the deflections go. So I always have to think about it. Remember, the upstroke, it going up, okay, is going to be exhaling, all right? So if somebody's got pretty normal square type of waveform, like you see in the very first wave, it should look kind of box-like, all right? As you exhale, you get the little air out pretty quickly, and it's continuous that as it's coming across the top there, how much CO2 is coming up. And then the second you take that breath in, boom, it just drops, because now we're just sucking in outside air. And in the normal atmosphere, there's just no CO2. There really is. I mean, we talk about global warming being from CO2. It's minuscule little changes in the amount of CO2 that affect global warming. So there's very little, almost no measurable by our capnography CO2 in the air. So the minute you breathe in, boom, it plummets. Okay, so the next breath, here, this is somebody who's intubated. We're seeing that as they exhale, the CO2 comes up real quickly, but then it starts drifting off, and that's because of the leak around the tube. Now go to the next waveform, and this could be just a side stream. All right, they show a normal waveform. The next one, well, again, this is trying to get the CO2 out, all right? Gives you the shark fin, kind of, instead of the orchids. It's very sloping up because I'm trying to get that CO2 out, I'm trying to get it out, and finally, it's only like really near the end, the high concentration of CO2 from way down the alveoli finally gets out, and we get that peak out there. This is the one, as EMS professionals, we better be able to recognize this. That kind of slope, that's the one that will kill your young patients. Okay, we better recognize the shark fin. That's the one you want to be looking out for.
So Dr. Giorgio, in terms of like differentiating between a COPD patient, which is a chronic obstructive disease, and then like a anxiety, hyperventilating patient.
Okay. I love it. You know, the veteran medics are the ones who ask the best questions. You know, you and Jetty and others. That's going to be in the second half. We're going to compare what do you expect to see in the COPD patient, that's an obstructive patient, versus the young asthmatic with severe bronchospasm. Again, there are different patterns and different presentations. We'll get into that. Sorry, Lori.
No, it's
Just
fine.
wanted to talk about the way it forms a little more.